to the next session. So next slide, please. So I was thinking about this and reading through the original article from October of 2016 that, talked about the overall goals for the National Partnership for Maternal Safety. And as I was thinking through this, obviously safety bundles are the way that we're going. That's kind of the set of evidence-based practice that we are doing. It gives us an organized system where all of that evidence is put together so that we can develop care practices, policies, procedures at all of our facilities. And so I was just kind of thinking about this, and I came up with this idea for this little image that I have on the right side of your screen, that we have that overall patient safety, perinatal safety goal. We want to address that safety goal within every birthing hospital, with every perinatal admission, regardless of antepartum, intrapartum, or postpartum, and every patient. So it's this overall theme that I know that I'm hearing on the nursing side through AWAN and other organizations, that we want to be addressing that culture of safety and that culture of respect with every patient, every time, every encounter. And so I just kind of thought that this was a nice little kind of bullseye way to kind of look at why we're doing bundles in this way. Next slide. So we're going to start with the information that is provided through the AIM, or the Alliance in Innovation for Maternal Health Safety Bundle format. And so all of the AIM bundles, as we've talked about in the past with hemorrhage and hypertension, there's always been 4 domains, and this year, or late 2021, but you'll see it in all of the bundles as they're being updated, now have 5 domains. Those 5 domains are readiness, recognition, response, reporting and systems learning, and now respectful care. So respectful care was a bundle that was a standalone bundle at one point, and they decided it really needed to be added into all of the safety bundles. So we're not going to see the respectful care actually as one of these characteristics, because this is a little bit older bundle, but as it gets updated, they'll add that piece in. So we know that the overall goal for this safety bundle, can we go back one slide? The overall safety goal for the safety bundle is to reduce the frequency of OB, thromboembolism, and to improve our overall maternal outcomes. So obviously the first place that I'm going to send you to for resources is going to be safehealthcareforeverywoman.org. If you have not ever been on that website, I recommend that you go check that website out. They have primary OB bundles, there are secondary OB bundles, and then there's some other women's health kind of issues that they also have some information on. So if you've never been on the website, I recommend you go on there. If it's been a while since you've been on the website, I would recommend go back and check it out, because they've updated some information on there. Next slide. So like I said, we're going to start with the AIM bundle. So you can go on to the next slide. So this is what the safety bundle looks like when you go in and you can download this PDF. And so for the readiness domain, we're looking at every unit is prepared for assessing VTE risk. So specifically for this bundle, it's about risk assessment. They break this up into the outpatient prenatal care, your antepartum hospitalizations, hospitalization after either a cesarean or a vaginal birth, and then the postpartum period. So that is kind of a twofold component. The postpartum period is that initial postpartum period when your mom is in hospital and she has maybe changed some of her risk factors depending on how the delivery went, as well as when she comes to you for her postpartum visit. Recognition and prevention then moves on to, once we have a system set up for our units, that every patient, they have a standardized tool to assess VTE risk at these different points in time. So I'll just ask, go ahead and type in the chat for me. I'm going to try to put the chat over here so that I can see it as well. But let me know, do you guys do at your facility where you deliver, does everyone get at least an initial VTE risk assessment at the time of admission? And I'm just curious about that. So I'll see if anybody types in for that. obviously the goal is once we start assessing those goals or those risk factors, that then we have a standardized tool that provides education for those patients, and for our healthcare providers, what are we going to do? What is going to be the recommended thromboprophylaxis if she needs that? Response in this safety bundle, again, is at the unit level. And so this is having our standardized recommendations for for our mechanical thromboprophylaxis, having standard recommendations for dosing of prophylactic and therapeutic for pharmacology, and then recommendations for timing when you get into whether or not mom's been on treatment and it's time to do anesthesia. So and I know Dr. Campbell, in the last 2 sessions, we have covered this along with Dr. Johnson in what these protocols should be. The last one that's here is for every unit again, and this is just looking at our data. So when we look at our data, how many moms do we have that are being admitted into our units? And of those moms, how many have got the risk assessment done? And how many of our moms are actually being treated for that? And so that, as a system or reporting and learning system, is all about the data. All right, next slide. So I broke these down even further. I'm not going to go into a lot of detail on each of these slides. You can obviously come back and see them. But what we wanted to highlight is within the AIM bundle, the 2 scoring systems that are recommended are the Caprini and the Padua. So we can go to the next slide. So I see a comment that says, I'm not sure about whether or not we're doing a standardized approach at the hospital. So I'm going to try to remember that when we come around to the end, because I'm so glad that comment came into the chat box. So this is just an example, and I know Dr. Campbell showed this at the last session, the modified Caprini risk assessment model for pregnancy. It's been adapted for pregnancy, and then the modified Padua risk assessment model for pregnancy. So it is a little vague. It wasn't originally built just for pregnancy, so they had to do these adaptations or modifications to the scoring system, but something is better than nothing. So we want to have that. Next slide. And I'll show the Royal College assessment later on in the presentation, because I know we've talked about that. When we get to recognition, so remember, this is, we're ready, we have a system ready in place, we've got a risk assessment that's being done for every patient. This is where this comes in. So every patient who comes into our facilities, either in a prenatal setting or in a hospital setting, or the postpartum setting, then we are routinely screening. So this is everyone. So it kind of becomes like everyone gets screened for GBS. So everyone gets screened for VTE risk factors. And then we begin the education component and then the therapy if needed. Major guidelines come from lots of different places, and we've talked about that over the last month, and picking and choosing what works best for your patient population, what works best for you as your provider at the bedside, and what works best for those risk assessments. So it's going to be figuring out how to make the bundle work for you. Next slide. I am not going to read all of these. I put this in here, and it's a very busy, very wordy slide. But again, you're going to have access to all of our slides, so you can read through these individually. The biggest thing with the recommendations is you can see very quickly that there is universal recommendation for cesarean birth for all women and low risk moms. Then there's a secondary, you can see on the right in the kind of lighter purple or plum color, is if I have a mom with additional risk factors that is having a C-section birth. And then our antepartum and vaginal birth has its own set of kind of overall recommendations. So we want to make sure that we are making sure that we're stratifying those risks additionally by her type of birth. Next slide. So I told you that we would throw the Royal College in. You guys have seen this if you've been coming to ECHO for the last month. This is a very clear system for what do we do, what's her score point system, and then what's the recommendation for thromboprophylaxis. And this is out of the Royal College of Obstetrics and Gynecology. Next slide. So response becomes the most important thing. So the response should be appropriate to thromboprophylaxis based on the risk factors and her current clinical situation. So we don't want anyone to fall through the cracks. If we've done such a good job making sure that our units are prepared, we have policies in place, we're doing risk assessment. What do you do when you have a positive risk assessment? It's making sure that we then have a system in place so that we can make an appropriate response and follow either treatment therapeutic guidelines or prophylaxis strategies. Next slide. So again, the next few slides, I'm not going to go over individually. This is really about care and treatment, time front lines for utilizing heparin and when you need to turn, how long you need to wait, close to birth, or if you're going to have imminent childbirth, or how long your patient is hospitalized. But this is all information that you can gather either from the AIM website and also through the article that is highlighted for you at the bottom of the slide. Next slide. Again, recommendation specific for what is our response for vaginal birth and cesarean. And then the next slide adds different risk factors for extended postpartum thromboprophylaxis. So if those moms have delivered, once she's up and moving and she was in low risk vaginal delivery and she's up walking around the next day, then we don't necessarily have to continue treatment versus a C-section mom that's maybe going to be in bed a little bit longer, or she's got some other risk factors. Next slide. Timing of anesthesia, you have all of the information here for how long the recommendation is for how long we delay for epidurals and any other concurrent NSAID use. Next slide. Again, our reporting and systems learning is just about the data. So we always have to think about when we get ready to start, say, for example, you decide, I want our facility to really work on this as an individual facility. We do have safety bundles that we work on at the state level where the whole state is working on it. For example, we're working on postpartum hemorrhage and OB hemorrhage. But we have to think about how are we going to do those measurements? How is our charting system going to be able to pull that data for us so that we can be able to get the measurements and make sure that we are getting everyone every time. So everyone's getting the risk assessment and everybody's getting appropriate treatment. So you may want to talk to somebody that's a data person at your facility in order to make sure your charting system is able to pull that data for you. Next slide. So as I was researching and looking for great information to share with you all today related to the AIM bundle, I decided to go check on my favorite, number 2 favorite place to go, and that's CMQCC, so California Maternal Quality Care Collaborative. And they actually do have a bundle for this. So next slide. So they have a toolkit, not a bundle, I'm sorry. And it mirrors everything that is recommended from the National Partner for Safety as well as AIM, but in their great California way, they have lots of beautiful flow diagrams and algorithms for you to use. So again, it's still the same 4 time points in the pregnancy that we're looking at. Next slide. So I think you're going to like the way that this is laid out, at least I do. If you're an algorithm and a color person, this gives you the green is the low risk, the yellow is the medium risk, and then that reddish color is your high risk mom. So it gives you a really easy way. It really doesn't matter if you use what AIM has versus what California has. These are both free downloads. You just have to go in and register onto the CMQCC website. So you can go in and do that. It's a free registration. So this is a recommendation for first prenatal visit screening. And then we've talked before with different cases about re-screening. So especially if I had a mom who maybe was recommended treatment, she's afraid to be on meds, doesn't want to do the meds, that then we said, okay, the next time she comes to visit, then we need to do that screening again, do that education again. So this may be kind of a good way to help your staff kind of get through some of that assessment, risk assessment piece. Next slide. So they break the antepartum non-delivery hospitalization. So you have a mom that's maybe in for elevated blood pressures and we're ruling her out for preeclampsia, or maybe we've got her in for rule out preterm labor. So we can do that risk assessment and follow that algorithm for whether or not she actually needs the treatment or the prophylaxis. Next slide. They do give a really nice little chart for vaginal births. Next slide. As well as for cesareans, and they add these extra major and minor risk factors, which I like the way this is laid out. It just makes sense to me, and it's really geared towards that pregnant mom, and it's not so much some of the other risk assessment tools are geared more towards just your med-surg normal patient, but I really like the way this to me in my eyes as I'm looking at assessments and trying to figure out ways to look at things. I really liked the way this looked. So if you find this helpful, I would again recommend you check out the website and download the toolkit. Next slide. They also add some other recommendations based on your BMI levels. So they have a BMI less than or equal to 40 and BMIs greater than 40. So I know that in all the charts that I read on a regular basis, we are seeing more and more of our moms in childbearing years be in that BMI range greater than 40, which is our class 3 obese moms. So it's obviously something that is not going away anytime soon. So we want to make sure that we're highlighting that and remembering that those moms do have an additional risk factor. They also have really nice, and it looks very similar to what is in the 2016 article about medication and timeframes. Next slide. And then this is the risk assessment and for post-delivery / post-discharge. So again, I really like the way that they lay out that low risk to high risk, medium risk, and give you very clear kind of yes, no, and then we move on to the next piece of the algorithm and whether or not she needs to be on anticoagulation. Next slide. So because we looked at California, we also wanted to throw in a couple of additional resources that I found from the RNC-OB. So we can go to the next slide. So they too have a very pretty colorful algorithm. And I know Dr. Campbell has said that he really likes the risk assessment for Royal College. So I thought this pairs really well together when you're able to see an algorithm that gives us does she have any, just that looking at the antenatal assessment on the left-hand side of the slide, that any previous VTE except a single event related to major surgery immediately goes into a red high risk category. So it's just a nice layout, and I'm all about nice, easy visuals, because if you have easy visuals, you have an easy algorithm, you're more likely to use them. Next slide. And they also have, so this is again just in color versus the gray version that I showed you a couple of slides ago. What I thought was interesting here, and it highlighted to me because it was in I guess color, but the bottom of the risk factors for VTE has transient risk factors, and hyperemesis just sort of popped out to me in that, and it never popped out to me visually before, probably because I hadn't researched it quite so well, but that puts her in a medium risk factor, and where we would be considering doing thromboprophylaxis after 38 weeks. And it just was one of those things that just popped out to me as something that we see a lot of moms that we're admitting for hyperemesis. So are we thinking about VTE prevention with those moms? Next slide. All about what makes you think, right? And so I couldn't not see what ACOG has available for resources for you. So there is a practice bulletin. It was released in 2018. I believe it has also been reaffirmed more recently, 2021. I believe they did look at it and reaffirm that VTE. But this, I know as Dr. Campbell and I were going through the slides, this thromboprophylaxis, the pharmacology piece for pregnancy and postpartum is really nice chart that gives you what your antepartum and postpartum management should be for that. So another beautiful resource for you. I'm sorry if it's a little bit blurry on your slide, but you can pull that from the Green Journal or from the ACOG website. And then I have to shout out, because I know I've got some nurses on the line today, but I was reading through CMQCC's toolkit, and they really highlighted that nurses play a pivotal role in the prevention of both DVT and PE among pregnant and postpartum women. We know that prevention strategies are not limited to that timely recognition, early diagnosis and treatment and education, but all of that can have long-term effects on women's health. And that long-term benefit of early diagnosis is a decrease in the risk of post-thrombotic syndrome that could lead to long-term pain for those women. And so we all have a role in this, all of the providers. It's very much multidisciplinary that I thought was important just to highlight. So it doesn't have to be just that the providers are doing or just that the nurses are doing these risk assessments, but we're all working together regardless of the level of provider that you are at the bedside, either in the, again, antepartum all the way to postpartum and delivery. A1 also has a couple of articles of interest for us, so you can go ahead to the next slide. They do have standardized practices for addressing maternal VTE, and this, if you're not a member of A1, you can still access the practice briefs and the standard policies. So again, it's just another reference point or resource when you're helping to provide education to your staff. Next slide. So I'm going to preface this with the next slide may look a little crazy and busy just at the front end. But again, I told you I like algorithms and I like color. So for me, I was trying to figure out a way where we could put all of this together. So along the center, and I know, Rachel, if you could just kind of point to where it says pregnancy there. So imagine that this is our pregnancy timeline. So we're going through that initial, she finds out she's pregnant all the way through the postpartum period. So that's our timeline. To me, this was just a visual that kind of helped to guide how do we get through doing all these assessments and making sure all these assessments are done each time. So at the very beginning, if I've got a mom that's coming to us pre-pregnant, she's coming for just her normal checkup, but we know that she has maybe some VTE risk, we'd want to talk about, hey, are you thinking about getting pregnant? And these are some of the things that we want to be discussing and thinking about in your pregnancy because you have a known VTE risk. And then we move through actually in that initial prenatal period, and are we doing that risk assessment? And does she qualify? Then we drop down to the purple box down below and we see, does the patient qualify for prophylaxis? Yes or no? We give education and we begin that standard treatment. So we fall into each of these lines at each of these moments, either the antepartum, the delivery hospitalization, that postpartum visit, that it all leads down to, are we doing that risk assessment? Does she qualify? Has anything changed? And then are we doing treatment? And I wanted to add in the provider piece. So the provider piece, patients at the bottom, providers up at the top. We have to make sure, it's great that you guys are on Echo here, but we also have to be making sure that we're doing other education, that everybody in our unit, again, because you're not going to be able to accomplish every patient, every encounter, every time, if we're not all getting that same level of the importance of why we should be doing this VTE risk assessment. So this was just kind of my way of putting it all together. And so if this is something that's helpful for you, or at least something helpful to maybe show to your staff and talk about how we're all have a piece in this, then by all means, you're more than welcome to use this. This is just kind of the way my brain works. So another piece of this, the next slide, is how do we get that patient education out there? And so I know that we've talked with a couple of the cases over the last month that, you know, what do the patients know? Well, they don't know what they don't know. ago, and they may have heard scary things about the medicines that we're on. And so this is an example of patient education that CMQCC has specific for VTE for the patient. So the way that AIM and CMQCC is the quote that I hear a lot when I'm in national meetings is that we steal shamelessly and we share graciously. So this is something that if you think this really would work for my patients, then CMQCC says, then utilize it or fix it to make it match your patient population. So it's just a great handout to make sure that moms understand some of their risk factors and what symptoms to look for specific for VTE. The next slide shows the urgent warning signs, urgent maternal warning signs that Safe Healthcare for Every Woman has available. What I like about this one is the QR code, the QR reader. So I know, like at our hospital, this is hanging up in the hallway. So a patient can walk by and say, oh, I want to see that. And if you scan that QR reader, this PDF and the link to this part of the website pops up. And then the mom can actually click on, for example, a headache that doesn't go away. And it'll bring up more information and very specific things. So for our VTE one, this would be swelling or redness or pain in your leg. So they can click on that and it will give them specific things that they should be looking for and when they should call their doctor or go to the hospital. So I do like this, and this comes from AIM. Next slide. So before we get into getting to the case, this is where I would like to see, does anyone have any questions? Is there anything that we kind of want to circle back to? And we